Welcome to The Explainer. Today, we are stepping into a truly legendary medical event in Egypt. We're talking about the rounds of Professor Mohamed El-Alfy. Now, this isn't your typical university lecture. This is a famous gathering at Al-Azhar University, where doctors from all over Egypt, and even from Yemen, Syria, Iraq, and beyond, bring their most baffling cases. These are real people, real patients who've been searching for answers, sometimes for years. It's a place where the toughest medical puzzles get a fresh look, and very often get solved.
Doctors present cases that have hit a total dead end, and they're looking for a new path forward. But what really makes these rounds legendary is the follow-up. The diagnoses aren't just theories, they lead to new treatments. And then, week after week, the doctors in attendance see the best proof imaginable. The patients themselves, walking back in, dramatically better.
Today, we're diving into one of those incredible, real-life cases from those very rounds. And this story, well, it begins right at the edge of disaster.
So, let's jump right in. We're not starting with a history, we're starting with a crisis, a true life-or-death situation unfolding in the ICU. Okay, so you have a 48-year-old woman. She's got hoarseness, her face and lips are puffy and swollen, and her airway, it's compromising, fast. This is a code-level emergency. Every single second counts. Now, the sharp residents in the ER, they saw the danger right away, got her to the ICU, and called the professor. And that quick move probably saved her life right then and there.
So the team does exactly what you think. This looks like anaphylaxis, right? So they push adrenaline. Nothing. No change. They give a high dose of steroids. Still, absolutely no clinical response. And right there, that's your first massive, jarring clue. Something is very, very wrong here. The standard playbook is failing, and her airway just keeps on closing.
As the team is struggling to manage this crisis, a piece of information comes out from the family history that is just bone-chilling. This has happened before in her family. 2 of her siblings are dead, and they died from the exact same thing: sudden, unexplained suffocation. The stakes in that ICU room just went through the roof.
To really get why the standard treatments aren't working, we have to look back. Her medical chart isn't just a record, it's a story, a decade-long story of pain, confusion, and a whole lot of surgeries that never actually solved the problem.
6. Let that sink in. 6 times. Surgeons opened her abdomen. They were going in thinking maybe they'd find adhesions causing her pain, but almost every single time, they found nothing that could explain her agony. Each operation was just another dead end in this painful 10-year-long maze.
The family history is the absolute key to this whole case. I mean, it's like the Rosetta Stone. Out of 6 siblings, 2 are dead from suffocating. The other 4, including our patient, all have this vague history of recurrent allergic manifestations. That is not a coincidence. That is a massive, screaming pattern pointing straight to something genetic.
So let's go back to the ICU. The patient's life is hanging in the balance. The team is running out of ideas, and Professor El-Alfy reviews the case. He looks past the immediate crisis and he sees the whole tragic picture: the failed surgeries, the allergy that doesn't act like an allergy, the family deaths, and he connects the dots that everyone else missed.
This is the million-dollar question, isn't it? What one single thing can explain all these seemingly unrelated problems that cross GI, surgery, allergy, critical care? The answer required a total shift in perspective.
And there it is. With one definitive statement, Professor El-Alfy cuts through a decade of confusion. This is not ordinary allergy. This is hereditary angioedema. And that one observation, it didn't just diagnose her, it completely reframed her entire life story.
But you might be wondering, why is the larynx so uniquely vulnerable? Well, there's a brilliant anatomical insight for this, which was highlighted during the rounds by Professor Mohamed El-Alfy. And it all comes down to a specific feature of the cricoid cartilage. And right there, that's the anatomical trap. The cricoid cartilage is the only complete cartilaginous ring in the entire airway. All the others are C-shaped. Because it's a complete circle, it cannot expand outwards, so when those submucosal tissues start to swell up from that bradykinin flood, the edema has absolutely nowhere to go but inwards, closing off the airway rapidly and catastrophically, almost like a noose tightening from the inside.
All right, so now we have the diagnosis, HAE. Let's start connecting the dots and see just how elegantly this one condition explains every single bizarre and tragic part of this patient's case.
The key difference here really comes down to the biochemistry. A typical allergic reaction is driven by histamine. HAE, though, is a completely different pathway. It's driven by a molecule called bradykinin, and that is why adrenaline, steroids, and antihistamines are totally useless. They're targeting the wrong chemical pathway. Even the rash is different. It's not itchy like hives, it's a painful, deep swelling.
The mechanism is basically a cascade, like a set of dominoes. It all starts with a genetic deficiency of this one protein called C1 esterase inhibitor. Now, this protein's job is to act like a brake on the bradykinin system. Without that brake, the system goes wild, which makes blood vessels leaky. Massive amounts of fluid pour out into the tissues, and you get this severe swelling, angioedema, anywhere in the body.
And once you understand that, everything just clicks into place. Her closing airway, that's laryngeal edema. Her terrible abdominal pain that looked just like a surgical emergency, that was massive swelling of the bowel wall. And those 6 laparotomies, all of them were heartbreakingly unnecessary procedures for HAE attacks that were simply misunderstood.
You know, the most important part of these rounds isn't just about getting one diagnosis right. It's about learning the lessons that will help us save the next patient. So what are the crucial takeaways, the pearls of wisdom from this case?
This is what every clinician needs to know. These are the red flags. If you have a patient with angioedema that doesn't respond to standard treatment, especially if they have a history of unexplained abdominal pain or that telltale family history, you have to have HAE on your differential. These are the signs that can stop a decade of misdiagnosis in its tracks.
And here's the best part. This isn't just a theoretical diagnostic victory. It's real. The patient was started on the correct therapy, fresh frozen plasma and tranexamic acid, and her condition stabilized. She actually came back to the follow-up rounds, improved, so everyone there could see the outcome. The diagnosis led directly to effective treatment that kept her out of the operating room and out of the ICU.
So management is a whole different ballgame from allergy. The airway is always priority number 1. Medically, you're trying to replace that missing C1 inhibitor or block bradykinin. And just as important as what you don't do, you avoid triggers like ACE inhibitors and you prevent the harm of unnecessary surgery. For our patient, getting the right name for her condition changed everything. And there's this incredible real-world postscript to her story. After her diagnosis, she came into the hospital again with that same severe abdominal pain. But this time, instead of being rushed to surgery, she was given the correct treatment, and she got better. Now get this, at that exact same time, her sister, who is in another country, was having the exact same attack, and she did undergo another unnecessary exploratory surgery. That stark contrast just perfectly shows how a correct diagnosis can literally transform a life of suffering into one of control and, finally, hope.
You know, in this era of high-tech scans and advanced lab tests, these cases are such a powerful reminder that our most important diagnostic tool is and always will be a meticulous history. It's about really listening to the patient's story, recognizing when the pieces don't fit the common diagnosis, and having the courage to just stop, think, and consider the alternatives. And that leaves us with one final question to ask ourselves. In your own practice, in your own clinic, is there a patient you're seeing for a common diagnosis where the facts don't quite add up? The next case of HAE, the next great diagnostic save, could be hiding in plain sight, just waiting for a clinician who's willing to dig a little deeper.